Is on the healthcare networks of the future, and it's chaired by Deborah Ellis, Principal Carpenter Ellis, and you've heard from Deborah already, so let me introduce her and leave the panel over to her. Welcome, Debbie.
Thank you, Ralph. Hello again. This is quite different. This is about one part of the industry. We've talked very broadly. We were talking consumer goods at one point and meat at another, and we were talking about them all in the same way. Here we're going to take a vertical, and we're going to talk about one very large, very important industry. And I think the first question, probably in your minds, is, well, I don't work in healthcare, why is that relevant to me? And I guess the very obvious answer is that we're all customers of the healthcare systems. We're patients, we're trying to avoid being patients, and so what comes out of that system is very important to each of us individually and personally. I think the other reason that I think it's important, and I have to state my position here, I've consulted in many, many industries, but I haven't consulted in healthcare. And a couple of years ago, that for some reason started to dawn on me that that was an area that I wanted to research. So instead of working in it, I've started researching it. And it's a different discipline, and it's a different approach. And I think almost I didn't want to be researching an industry that I'd worked in. And I also want to research in an industry that I thought was very important and that I would feel good when I eventually get my PhD at 75 and, that it may contribute. So that's the context of why we're talking health. And I think the other important point is, I don't know about you, but I've found that you learn the most when you think about the hardest problems. You learn about the simpler industries when you think about the most difficult industries. And I think this is the most difficult industry. It's incredibly complex. It's multi-layered. It has, at the end of the line, a patient who in some states cannot even articulate what their needs are. There are incredible levels of knowledge embedded in the industry. The knowledge is so deep in some of those areas, so sophisticated in some of those areas, that it is very difficult to challenge with any other model. And I think that is probably the fear of many of us who come in, and I talked to Martin, and I'll introduce the panel in a minute, and I think you'll be very comforted when you hear a little about the panellists. But when I talked to Martin about what happens at a medical conference, and I said, I bet it sounds quite different to this. And yes, it does. Of course it does. It's about evidence-based. It's about fact. It's about conclusions that are built on logic. And you have to say that when we talk about our discipline, we have a lot of opinions. And we have a lot of things that can't be proven. And it's different. And I would think that for somebody like a doctor with a supply chain professional coming along and saying, listen, I know how you can do this better, it would feel uncomfortable. It would feel, well, where's the evidence? Where's the logic? Prove to me that this is going to be better than me saying that I want to order this drug for this patient and this for this patient and this for here, and you can keep 3 lots of stock for them. Prove to me why I should compromise my clinical decision because it's better for the supply chain. So I think that is one of the core and important issues, but there are many others. And I think that level of complexity is quite different to what we see in many of our other complex situations. So let me introduce the panel and tell you why they're here. Because we talk about genetically engineering. We've had challenges with this panel because we've had some outstanding... This is a health panel, and we've lost through ill health. We've had fathers who've become ill very suddenly. So we've lost some people, but we were determined that we were going to have a genetically engineered panel that suited what we wanted to think about. And so beside me we have Professor Martin Selink. You've heard him speak last night, and I'm sure when you heard him speak, you realised that this was somebody who was important. And it was not because he had just letters after his name. He was important because he made the effort to make a difference, both at the very personal level of young children in dire situations, but at the global level of saying to the UN, this is an important problem. So I think we're very lucky to have him here. And the way that I would position this is that Martin is representing our customer. He's representing the patient, the end of our chain. And I think that's a real advantage that our panel has, is that we have the voice of the customer on the panel, because he sees every day and knows intimately the patients that the supply chain must eventually service. But he also is that second-tier customer who makes decisions, and we're all familiar with two-tier customers, a consumer and a retail customer. So I think it's a very unique position, and I think we're lucky to have both the voice of the customer, but also the voice of a global diplomat and advocate in his areas that can give us that perspective. So a very close perspective, but a very far back perspective as well. So I think that's wonderful. I think next to Martin, we have Kevin Smith. Now, why Kevin and I are important in this, and is because we are the people looking through the supply chain lens. So what we're trying to evaluate as we do that, and what I want you to try and evaluate, is does the supply chain have anything to bring to this equation? Sometimes we get a bit carried away with ego, and we have ego about our professions as well as about our individual selves. And sometimes, perhaps, we can't solve problems. Sometimes, perhaps, our lens isn't appropriate. Now, I think the supply chain lens has something to offer in this area, but perhaps, that's not the case. Kevin thinks the supply chain lens has something to offer in this case, because we've discussed it and we know, we see some of the same things. But we'll let, ultimately, it will be Martin and the patients who make that decision. So Kevin has experience both in the grocery field, the consumer goods field, and the pharmaceutical field, and at a retail level. So he has seen and operated in those spheres and been able to contrast them. But also, he has seen and worked with the people that have worked in developing countries, and we'll talk more about that later, but there's important and interesting work going on there. So he can give us perspectives from different angles, and that's what we wanted to achieve here. And on there we have Farhana from IBM. And Farhana is here because IBM is doing some really interesting things in this space. I think we talked in the early panels about innovation and about design, and I think one of the things that John and I have talked about over the years is true innovation is very, very often supplier-led. Nobody stands back and says, I want it, and this is how it's going to be. If you give me that product, then I will buy it. True innovation is about intelligent assessments of need and producing and being strong and brave enough to produce results that you can push out there in the market and present a solution. And I've been watching what IBM IBM have been doing for a few years, and I know it's probably been quite a hard struggle for them, because they are talking big systems and big, complex and hard to grasp solutions, and sometimes the markets aren't ready for that, and it's very long term. But I've been very impressed with the way they've sort of hung in there, and so I really wanted to hear about that. And just to finally position this a little bit more, there are two pieces I want to tell you. Firstly, when you talk health, it is so broad. Where does it start and where does it end? So what we have talked about are the different levels. So at one level, you have a health system, and particularly in the developing world, that is one big system run by a Ministry of Health and very, command and control in its format. In other cases, it's a government struggling with health and how to design it and create flows through it, such as the NHS in the UK and in all of our countries. The next level down, you have aggregations forming, such as groups of hospitals. The next level down, you have the individual hospital, and flowing through there at some level, which wouldn't fit a diagram neatly, you have the whole pharmaceutical distribution through the public system and the private systems. And then at the very bottom and core of it all, we have the patient. And so those are the sort of levels, and we're thinking that there's supply chains in all of them. When I've looked at insulin, and I look at it from a patient perspective, what I can view it as is supply chains coming towards, with insulin syringes and strips, and coming towards this patient. And that's a different way of viewing the world, but I found it was the only way that made sense to try and understand availability of those products. So that's one lens, and I think the other is to say, well, what is supply chain in this context? And I think perhaps Margaret Stave made a comment to me on Monday, which she probably forgets now, but she was thinking how to educate her people to have this high-level view and contribute at this very strategic level. And she was sending people off on courses. One of the courses she sent them off on to was systems thinking. And I know John, in his doctorate many, many years ago, uses the systems thinking as an underpinning base. And if you look at the supply chain work that's done at the very theoretical level, it says this is about systems thinking. And it's how, systems thinking says, how do you make this system work most effectively, and it pays heed to the interdependencies between it. So Martin doesn't know sometimes what we mean by supply chain. Well, Ron's trained him pretty well, but he will still question that. But systems, work much better as to describe what happens, for example, in a hospital. So that's the lens I wanted to frame our discussions on. And at that point, we're going to talk firstly about each of the panellists' perspectives, and then we're going to talk about some layers on top of those perspectives to try and understand a little bit more. So firstly, if I could ask each of you to give your general perspective of this topic and what's happening in this area. Martin?
Thank you very much. Thank you also to John and the organisers for inviting me. This is a completely different ecosystem that I'm used to working in, but I really think that it would be very useful for there to be more situations like this. I'm a practicing physician. I'm a paediatric endocrinologist. I deal with hormonal disorders, and the main hormonal disorder I deal with is diabetes. But as all of us do, I've worn and continue to wear different hats. And one of the hats that I did wear was as president of the International Diabetes Federation. And the International Diabetes Federation is probably the largest, if not possibly one of the largest then, consumer organisations, which is based in Brussels. And it is the federation of all of the diabetes associations in the world, So the American Diabetes Association is one of its members. The Singapore Diabetes Association is one of its members. And as such, the International Diabetes Federation represents about 1/3 of a billion people with type 2 diabetes predominantly. And also then there's the other group, the people with type 1 diabetes and people with gestational diabetes. These issues of diabetes really go back to an area of healthcare that I think that we have not really come to grips with because we don't know what the answers are. We are only just starting to understand the magnitude of the problem that's facing us. If I look back and just say, as a practicing doctor, I work in a well-run hospital and I know when a patient goes to the operating theatre, everything will be there. All the supply chains work beautifully and they can trace, if there's a bad scalpel, they'll be able to trace it right back. So all of those supply chains for an operating theatre in the area that I work in the hospital I work in, are working beautifully. So congratulations to you as a collective industry. But the new paradigm is that we're trying to keep people out of hospital. There is a tsunami of new diseases, the non-communicable diseases. I call them new because in many countries they were almost unheard of before. And these non-communicable diseases, and there are 4 big ones. The first is cardiovascular disease, so heart and strokes and peripheral gangrene. The second is all cancers. The third is chronic respiratory diseases, and the fourth is diabetes. Those 4 big non-communicable diseases, as opposed to communicable diseases like infections, those 4 NCDs now account for 60% of global mortality and global morbidity. What is counterintuitive is that these diseases affect the developing countries more, and 80% of the morbidity and premature mortality occur in the developing countries. They're having such a profound effect that they've now, even at this late stage, are now being factored into the Millennium Development Goals because they're affecting the development of these underdeveloped countries. What sort of numbers are we talking about? Well, let me just deal with diabetes, which is just one component of these big 4. At the moment, the estimate is that there's about 336 million people with diabetes. Every 10 seconds, there's another 3. Every 10 seconds, some person has died because of diabetes. So the numbers are incredibly large. By 2030, there'll be over 500 million people with type 2 diabetes. In countries like India, approximately 10% of gestation of women undergoing having a pregnancy have gestational diabetes. So the numbers are actually quite immense. The Harvard School of Public Health and the World Economic Forum have estimated that the cost of these NCDs is about over $30 trillion over the next 20 years, equivalent to 48% of the world GDP in 2010. In the developed countries, the side effects of just diabetes, of renal disease, is threatening to bankrupt the healthcare systems, the dialysis costs, for instance. So the causes are multiple, and we don't understand truly what the causes are. Some of it due to aging, some are due to genetic causes, a lot of it due to our lifestyle, obesity, sedentary activities. So we don't really understand the full causes of this. In a way, it's simple. Eat less, walk more, eat less salt, stop smoking, don't drink as much as you do. All very simple things, but they impact on human behavior. And as you know, human behavior is very difficult to change. So these epidemics, the NCD epidemics, are still flourishing. The second thing is that whilst we've not come to a clear understanding of how we can turn these epidemics around, in terms of their treatment is really out of a hospital. So the majority of the treatment is the patient who then becomes the most important manager of his or her treatment. And that patient, I think, should really be the focal point of your supply chain. It shouldn't be the healthcare or the pharmacy. It should really be the patient. And if one accepts that, and understanding that these patients tends to be out of hospital, there's a gap between what you provide and what the patient then will accept. And there's this gap of knowing how to work the insulin pump, knowing how to adjust the medication. So education turns out to be a significant gap that needs to be filled by someone at the end of the supply chain from the logistic point of view and its usage. You may design a fantastic insulin pump, but unless there is the knowledge of how to use it, it will not be used. So the other element about the NCDs, the non-communicable diseases, is that they're all interrelated. So a person with diabetes does not need to be treated only for diabetes. If you do that, then you will not decrease the mortality. You also need to treat their blood pressure. You also need to treat the cholesterol. So all of a sudden, it's not one thing you're treating the blood glucose. There may be 2 insulins involved. There may be insulin pens or an insulin pump. But there's also cholesterol medication. There'll be medication for triglycerides. There'll be at least 2 medications for the control of hypertension. These people often get depression as a side effect, so there may be an antidepressant. And many of the people with an NCD, to increase the quality of their lives, may end up being on 6, 8, and 10 medications. So this is a kind of a new problem for the health systems. And the healthcare networks, the healthcare systems are trying desperately to get evidence-based algorithms to be able to treat these. So just to finish up, once all of these things are presented to the patient, then needs to be surveillance whether they are working. So the patient with diabetes or any of the NCDs needs to have their eyes checked, kidneys checked, feet checked, blood pressure measured. So all of these are another set of alignments of processes that impact on the patient. We don't know what the answers are, but the size of the tsunami is absolutely staggering, and the only solutions will be evidence-based, and it'll be logical algorithms that will be put in place, and your knowledge will be absolutely essential.
Thank you, Martin. I'd like to turn to Kevin now to look through his eyes, which have all that supply chain experience from all those great companies, looking at this new problem, and not for the first time, I recognise.
Well, thank you, Deborah, and thank you for all of you who are sticking with it to the bitter end here, because being on the last panel, of course, is quite a challenge. And Doctor, ordinarily I'd say you're wasting your breath talking to supply chain people about eating less, drinking less, getting more exercise. But I think it's important for us to remember that, as Deborah said, why is this subject important to us in supply chain? It's important on 2 different levels. 1, because it's a critical part of our lives. 2, because it affects each one of us. And there have been 2 fundamental shifts in supply chain, I believe, in the last 10 or so years. The first is a shift where we've moved from supplier-directed healthcare, that is, doctors and hospitals telling you what you had to do, to more of a consumer-preferred healthcare, with consumers actually taking a much more active role in their own treatment. And there are really 3 different kinds of healthcare consumers. There's the informed and very involved consumer, the person who has a primary care physician who goes for a physical every year, who actually does try to watch what he eats and drinks. These are the people that are very conscientious about taking their prescribed drugs in the way that they're supposed to be taken, et cetera. There's a second kind of consumer, and this is the person who is probably less inclined toward healthcare for any number of reasons. Perhaps they don't have insurance, perhaps they don't trust doctors, perhaps they had a bad experience at some point in their life and they just don't want to do it. And then there's a hybrid, and the hybrid is the person who thinks they know a lot about healthcare. Perhaps they're self-diagnosing, they're using the internet. And the American comedian Dennis Miller said recently, and I thought this was just fantastic, "Thanks to the internet, never before have ill-informed people had such a stranglehold on vague facts." And I think this speaks to the way many people are actually treating their health care today. On the other hand, the second major shift has been a general embracing of good supply chain methods and processes by very traditional and sometimes very stodgy institutions in the healthcare industry, hospitals, clinics, et cetera. And what I mean by that is originally you would have had a farmer in the field who hurt himself. If he broke his leg, he'd strap a piece of wood to his leg and try to get the bone to heal. Or, if he cut off a couple of fingers with the plow, you wrap it up in a handkerchief and hope that you don't die later that day. Then we kind of progressed a little bit further along to where you had semi-taught or self-taught individuals who knew a little bit about medicine, either through trial and error or because it was passed down generation to generation. Then barbers became surgeons. Eventually we ended up with hospitals. I think primarily hospitals were probably first put into general use just to make sure that we were able to bring combatants back into the war rather than have them die before we could have them go back to war and get killed in a more honorable way. This has progressed to the point, though, where hospitals became a mainstay of what we do in our lives. Hospitals have branched out now, and now we have not just big mega hospitals, but you also have surgery clinics, you have other types of health clinics. And leading up to what we had at CVS Caremark, and by the way, some of our competitors also had this idea, a clinic inside of a drugstore. And what this allowed us to do was transform ourselves from just being a retailer to essentially being a healthcare provider. And we really tried to embrace the idea that customers coming into our stores were not just customers, but they were in fact patients and lives that we could affect. And once you make that change, that fundamental change in your business, you're really addressing the whole idea of retail in a different way. So those changes have occurred now. People are actually taking a more aggressive approach to their own health care. And healthcare supply chains, the delivery channels, have changed significantly to become more convenient, much more technologically advanced. The idea, as the doctor said, that the correct instruments and the correct quality would be available in the operating room when it's needed is one thing. But these hospitals have also started to evolve to the point where they're actually embracing demand processes. So originally, a hospital would say, we're going to need bandages, we're going to need these types of drugs, and the idea would be to get more than you ever needed because you never knew when you were going to run out. Today, large hospitals are approaching this completely differently and saying, how do we deliver the best, most cost-effective health care? And one of the ways you do that is by embracing some of the more progressive methods in supply chain. Postponement. UPS, and I'm sure DHL has similar programs where they stockpile surgical implants. So we talked yesterday, for instance, about if you were going to have a hip replaced and you went to the hospital, the number of permutations on the different sizes of that particular instrument are just so staggering, no one hospital could keep that. But if you keep it in a central supply place, and then you do as UPS has, which is to create a system where they can deliver that product not in 2 days or 2 weeks, but 2 hours to any hospital. Now you've advanced the way we deal with surgery, and you've reduced the inventory and cash flow for the, well, you've increased cash flow, you've reduced the amount of cash invested for the individual hospital. So these methods and processes that we take for granted in the consumer packaged goods industry are late coming to hospitals, but they're coming on very strong.
Thank you. Thank you, Kevin. I'd like to turn to Farana now to hear IBM's view, firstly on health, and I think also I might ask her if she can talk a little bit about IBM's own advances in the supply chain, which are not insignificant in themselves, in both, affecting both the health area and more generally.
Sure. So first, again, I'd like to thank John and Deb for inviting me to be here. I'd like to first start by saying I'm not from IBM's supply chain practice. I'm actually from the healthcare group. We have verticals. So my role within IBM is really focusing on the growth markets. And for what IBM that means is it's easier to say what's not included, which is North America and some parts of Europe. Everything else that's developing and emerging is really what I focus on for healthcare, and I've been doing that the last 11 years. And as a result of that, I've had the fortune of actually meeting ministers of health across the world, as well as CEOs of hospitals and clinicians, to understand what their big challenges are in the healthcare space. And I think if you spoke to anyone in the healthcare industry, the three top areas are always cost, quality, and access. And obviously, every country varies depending, on access as well. And what we're seeing is actually that there's a huge strain in cost, as you would have heard earlier from Martin as well, from the chronic disease side. And 20% of the population account for 80% of the healthcare costs, but that's a huge strain. And in many countries, people don't have a primary healthcare system. So people just go to hospitals, which puts a huge strain on the hospital systems as well. And so I actually wanted to start by just sharing a really good example of where a government has taken a good charge in terms of trying to manage these issues of cost, quality, and access. And that's actually where we're sitting today, is Singapore. When I travel, I'm from Singapore. Most of the time, if I go to talk about IBM solutions, everyone wants to know what's Singapore doing in healthcare. It's almost a benchmark in terms of some of the work that they're doing. And really, the reason they're so far ahead is that they've really decided to put the patient at the center of the healthcare system. And what they've done is they've decided to restructure the whole country, and it's easy in Singapore, as you know, it's very small, to actually have 6 clusters of healthcare units. And in each of these units, they have everything from prevention and screening to primary care, to specialty centers, so eye centers, heart centers, to actual what they call restructured hospitals, which is just general hospitals, to community hospitals and palliative care. So this is all within one cluster. And when you're dealing with huge demand on the healthcare industry and a limited supply, the last thing you want is everyone that's sick with a cold running to the general hospital. And if you've had a hip replacement, you don't want that person staying in the hospital for 2 months for recovery. So the idea is, what they've decided is you need what they call right siting, which is making sure the patient is at the right point of care at the right time, getting the right medical treatment. And so that's actually how Singapore has restructured the way that it is. So geographically, you would go to your primary care physician as your gateway into the system. And that way, like in the case of my dad, who has 5 different doctors, he's not going to every single doctor and having to carry all his records and tell them what drugs he's taken from the other person. There's a lot of duplication of tests that get done in the healthcare systems today. Every time you go, it's like you're brand new to the healthcare system. They ask you the same questions. And so from a government perspective, they've not only got electronic medical records in all the hospitals, but they've built a national electronic health record across the whole country. So now every citizen in Singapore has a medical record from birth to death that can be accessed by all the public, private, and eventually it'll be private. Right now it's public hospitals, but even the GPs and even the military hospitals everywhere will have this. So it makes things a lot easier, obviously, as you transition. So from an IBM perspective, this has really been our focus, because if you've heard our big campaigns on Smarter Planet, Smarter Cities, it's all about smarter healthcare for us. And healthcare is not one organization. It's a system of systems. It's a network. And so how do you coordinate that care? As a patient goes through this system, and actually the whole idea is to keep them out of the system as well. How do you prevent them from getting in the system? And that's where analytics for us has been a very big focus, and I'll give some examples. But as they transition through this, how do you actually manage that care path of that patient as they go through? And again, there's all these issues with supplies associated as they move through all the information as well. So I'll give you a simple example. If a patient goes into see a GP and say they get referred in to a cardiologist, so they go to a specialty center and then they move in to the general hospital and have surgery, one of the tools that we can use, for example, is where we actually are able to do analytics to predict, is this patient high risk based on evidence in the past? So we look at historical data of patients in historical databases to say, based on similar patients, is this patient at high risk of being readmitted? If they are, then we can follow up with them at home and keep them out of the healthcare system, right? The other thing to do that we're using as analytics is to say, as they go through this progression path of, the GP to the specialty center to the, general hospital and then into, say, community hospital for long-term care, can we analyze this information to say what is the best utilization pathway for people that have hip replacements, right? Is it better that they spend more time in the community hospital or better that they spend more time in, say, a GP? So those are the kinds of things and tools that we're using because, again, as I said, for us, this is not just about dealing with a provider, and the idea is really focusing on the patient experience and making it easier for them. And then the last point I'll mention is that being from an IT company, I can tell you that healthcare is probably one of the biggest laggards in IT adoption in the world. And that's really because of the nature of the business, and it's a very people-oriented profession, and people are always a little concerned. But I think for us, in terms of decision support, et cetera, it's never taking away anything from the doctor. It's just guiding them in terms of evidence to see what else there is available that could help them make a more effective decision. But also, back to the point we heard earlier about retail clinics, is being able to see, is there other ways that IT can help enable things so that, as the patients go through the healthcare system, they actually do get into this right siding, the right care at the right time. You do go to the CVS clinic or wherever to get care for your cold. You don't go there when, you don't go to a general hospital. So that's just some general perspective.
Thank you, Fran. I wonder if, like me, you sometimes bring your own lens and think, what can we offer to this equation? I think it's interesting to hear what's happening here and to turn it back and say, what does that say about the consumer? If we've got a patient-driven health system and we're learning how to connect that patient with information technology and we're learning how to interpret their needs and their doctor's needs through that, what does that tell us, about working with consumers? I think that's a sort of interesting question. I would like to overlay on that a geography or a set of geographies and a set of conditions. And those are what we call developing nations. And I want to think about how the situation is different, and I want to hear the panellists talk about how they see the situation being different and the issues being different and the opportunities being different, and also what's the same. I will kick off myself because it's there's something that really inspired me a few months ago when I came across it. Melinda Gates, who you'll probably know is, part of the dynamic duo of Bill and Melinda Gates, who have taken all the wonderful proceeds and learnings from their experience with Microsoft and have turned it into a great deal of good in the most desperate parts of the world. And just before I tell you what Melinda Gates said, I think that is, to me, the most exciting thing that has happened in the last 10 years in developing supply chains. And it's about not just the money, because of course big lots of money came through Gates and Buffett and these, we have to say, wonderful Americans who not only make big money but think big about what to do with it, unlike some of our Australian mining magnates who make big money and worry about giving it to the government. But what that has brought is two things. One, big money, but two, a different mindset. And I think that in the long run is going to be as powerful or much more powerful than the big money. It's brought a commercial mindset It's brought some commercial drivers and some KPIs, and with it has dragged this idea of supply chain. And you'll see, coming with the $32 billion that the US government has committed through what they call the PEPFAR, and a number of other funds, but these big commitments, and the Gates money, and the different and Bill Clinton's foundation, through these different bodies, they have recognised that what they want to achieve is not achievable in Africa particularly if they don't do something about supply chain. So they saw what they wanted to do. The major thing that they were interested in addressing was the most urgent problem in 2000 on the horizon, and that was HIV/AIDS. A major issue, a major concern that HIV in Africa was, the curve was just astronomical. It was, enormous fear that this was not only going to destroy the health systems of Africa, but seriously impact the rest of the world as it spread from Africa to the rest of the world with very high incident rates. The people that harnessed that money recognised that they not only had to get the drugs that had just recently been refined enough to do some good to the patients that needed them, but they actually had to create a whole supply chain system to do it, because the current one was not good enough to get it there in the time frame or as widely as they needed it. But they had to do a lot of other things associated with that, which we would call supply chain. So let me first tell you what Melinda Gates said. She stood up, and I think in many ways spoke like a mother, and with a very simple comment, and said, "You know what I don't understand? I can travel to anywhere in the world, to any small village, to any outpost in the world, and I can get Coca-Cola. I can buy a bottle of Coca-Cola." She said, "I've never been anywhere that I couldn't get Coca-Cola." But when we go and look at these places and find that we can't get vaccines through there, that nobody's ever heard of the malaria drugs that we're talking about, that the local clinic did have, and she didn't use the example of insulin, but we know it's right, they did have it for a month, but then they didn't have it for 5 months. What does that mean to a child who needs it every day? So she posed the question, why can I buy Coca-Cola and I can't get reliable access to the core medications that society needs to keep people alive? So I think that's a very interesting perspective, and I'll just go a little bit further on, she didn't just say that. The people surrounding her and those several organisations who are doing some very good work did some important supply chain things about HIV/AIDS, which I will just quickly tell you what they did. The first thing was they defined true demand. And all of our supply chains, I think that's a really interesting question. What's true demand? We capture sales, but what's true demand? But in this case, it's a very important question, because the visible was those people who had been diagnosed at that point in time, which it turned out was a small multiple of the millions of people who actually were currently suffering from HIV/AIDS at that point in time. This is about 2000, year 2000. And that was a smaller multiple of the people who were going to have a problem in the next year. So they worked on actually capturing what that true demand was. And why that was so important was that the cost of the product, the antiretrovirals that would be able to treat patients, was very, very high. By capturing that 10, 12 times multiple of demand, they suddenly had a different economic equation. So going to a high value, low volume product, as it was going into Africa, became a low value, high volume product with a different commercial equation attached to it once they knew what true demand was. That was the very first important thing that they did. The second was they've worked out, and none of this is finished. None of it is refined to the last degree. It's in pockets. It's partly done, but there's some really important things done. They've aggregated procurement because fragmented procurement means fragmented demand signals back to suppliers, and little confidence that there will be an order from that ministry next year. Inability to plan capital equipment. So for suppliers and pharmaceutical companies, aggregated procurement gives them much more clarity. And once you've got that, you can start giving forecasts. The other thing then was, once you're doing that, you're starting to be able to think where in the supply chain to hold different products. And one of the, some of the initiatives that are happening are associated with holding medicine further back in the supply chain, which, although it has longer lead times, gives you much more flexibility about where to send it. And I think that's an important initiative that's we're going to see more of. I think strategic positioning, even for emergency relief, strategic positioning of emergency relief goods for the next disaster, which we don't know what it is, but that's a very important supply chain question to answer. And the other thing they did, and I think this is a core opportunity in this space, is they've started to work with 3PLs. And the way they've started to work with them is in new business, what I would call, maybe not new business models, but new business methods. And one of those is they work with a company called PhD, and I think they've extended this model to other third-party logistics companies, and it's called a plan-to-leave model. So they realised that the initial round of AIDS medication was going in parallel. The Ministry of Health systems were not good enough to get it where it needed, when it needed it. So they built parallel systems. Unfortunately, also vaccines did, and TB medications and malaria. So what they've realised is they actually have to lift the capability. So they're using 3PLs to lift capability. They're putting in a sophisticated 3PL into a Ministry of Health and saying, plan to leave in 3 years. While you're here, you need to plan to train the staff, develop the standard operating procedures, work out the inventory systems, and develop a capability. And when you go, you can mentor for the next few years. You'll have mentor relationships, but you must be out in this time frame, and the capability must be lifted. And this is a contract. Now, isn't that an interesting contract? And I said, well, what about the business? You've lost the business. Oh, there's lots of other places to go. They will move on to the next problem area, the next Ministry of Health distribution centre that isn't functional. So I think that gives some hope, but it's big. It's big scale, it's big imagination, it is big money, but it's actually not big money in terms of it's using the money much more efficiently and effectively. And it's not a finished equation, but I really think that there is so many lessons. There's so many lessons for what we need to do about diabetes and other conditions, but there are lessons too for our own supply chains. So, having talked too much, I'm sorry, I will now pause and ask Martin to tell us his Life for a Child work exposes him to the most critical situations, and ask his perspective on developing countries and the issues and the opportunities from the supply chain point of view, or generally.
Yeah, type 1 diabetes is really at the pointy end because insulin is life-saving and life-sustaining. Without it, the child dies. So really, if there's something to test a supply chain, you can't think of a better system to look at. And there's no doubt that a critical gap in the supply chain just eliminates the problem, so to speak. I was talking to a colleague from Indonesia, and in that part asked whether there was a problem with type 1 diabetes, and he said no, not really. And on inquiring further, is insulin available? He said yes, mostly. And then it turns out that there was a gap for a couple of months, and that did eliminate the problem. So obviously that's not, that's something that just has to be fixed. In a country like Mali, when we first started working in Mali, we were able to identify, looking at all of the medical centres, identify 10 children with type 1 diabetes. And we were communicating with them. By the end of the year, 8 had died and 2 were uncontactable. We now then put in a system of regular deliveries of insulin and syringes and glucose monitoring. There's now 140 children alive there, and and the numbers are going. In the developing world, there's no doubt that the best system that have been developed are the HIV systems. And if you take any article, any business plan, any supply chain protocols that have been written, and just substitute the word for HIV, AIDS, and slip in diabetes, then the whole that whole plan will just make sense. So the system that is being put in, the parallel system, has worked extraordinarily well, but has disrupted the governmental systems in many of the countries, and now it needs to be integrated. And then the other NCDs and the NCDs now need to be incorporated into a plan that's working, and that will need to be the overall plan for HIV/AIDS that's got to be put into primary healthcare centres, and then the NCDs put into the primary healthcare centres. What's also coming through, and it's also coming through in the developed world, is that there's not enough doctors. Doctors are the too expensive solution. So really one is looking at nurse practitioners, call them different things, but healthcare workers who've been trained up to a certain point, who are working according to either consensus or evidence-based protocols, and they know what they can do. There's a limit, and if they work along the checklist, they realise that they've come across something that they're not allowed or not able to fix, then refer. And it'll be that sort of a system that the IBM system will need to identify, and in fact already does. So healthcare workers to substitute for things that can be performed in a known sequence. There's a system developed for it. That's the solution. There just aren't enough doctors in the world, and the size of the medical problems is increasing at such a rate that we will never be able to qualify enough doctors for that. So there is a lot of hope, and the system of bulk purchasing, this is based, and there's some very good models on it. There's the Gavi, there's the Global Alliance on vaccine and immunizations, where countries, often at the World Bank or the IMF comes in, and it guarantees that there will be a market for 100 million doses of vaccine over the next 5 years, and therefore that vaccine can be produced in mass production at a low cost. And this sort of thinking, it's really at the level of the UN, where the UN is able to bring in farmers and service providers and bring them to the table, that will result in affordable treatment for many of the non-communicable diseases as well as the communicable diseases, and the actual dispensation or dispensing of it will probably be done at the level of healthcare workers, and there's a doctor who will be looking after the difficult clinical side of things, but not really those elements which can be readily put into a system and processed that way.
Well,
Kevin, you've talked about systems.
yeah, and I've done some work with USAID in trying to also create supply chains for HIV, antiretroviral drugs, family planning, antimalarials to sub-Saharan Africa. Unlike developed countries, the problem in a developed country is more one of compliance, getting patients to actually do what they're told to do in order to maintain their health. In the undeveloped countries, it's a matter of infrastructure. And in many cases, there just isn't any way to get these drugs to these places. And with all due respect to Mrs. Gates, because what she's saying is absolutely true, but if you're 100 kilometers from the nearest outpost, you're less likely to get a Coke. And if you do get a Coke, it's not going to be at 5 degrees centigrade, which many of these drugs have to be kept. So if you're in an area that has no electricity, that has no roads, and has no real good place to dispense drugs, then you've got a significant challenge in getting those drugs to the right person. Now, consider also, and this is a very selfish reason for being involved in this, but it occurred to me after traveling the world for 30 years that if you go through JFK or Charles de Gaulle or Changi Airport, we are only one flight away from a horrible pandemic. If some disease that has essentially been wiped out in the developed world gets onto a plane, and it's going to get onto the plane on 2 feet, and travels somewhere. Unknowingly, unwittingly, I'm not saying this would be a terrorist act, this would be just somebody who's ill, and if you go someplace where we have no defenses for these things anymore, it will spread virally, no pun intended. So when we talk about how to correct these problems, we're also talking about something, and I applaud the work that's being done. My experience is a little bit jaded. The ministers of health that we've dealt with are functionaries with their hands out looking for a bribe primarily. The reason that some of these drugs don't get to the places they're supposed to get is not because the minister couldn't figure out how to get there, but just because there's some underlying agenda within the country that prevents the drugs from getting to the people that need them. So we've got two real big problems here. One is the general geopolitical issue of can we convince these countries that they really need to get these things to their people? And by the way, many of the pharmaceutical companies are providing these drugs at low to no cost in order to accomplish this. So it's not even a marketing play for them where they say, oh boy, we're going to have millions of HIV patients in Africa. That's not the thing. The thing is just trying to get these drugs to people to help them, and the infrastructure is preventing us from doing that, as is the political aspect.
I mean, all of the work in development, they say that the governance is the base, isn't it? It's without governance, everything else becomes so much more difficult, and it's the platform to move forward. But of course, we can't wait for good governance, can we? We have to find ways almost around the minister, the guy with his hand out, or through him.
Well, and despite the nice things you said about the United States earlier, and one of the big problems we have in the United States is being so open. Every time we have an election, every 4 years, we recycle all of the people that are involved in these programs. So if you've got a good program going, and then you have a presidential election, and the political appointees get changed out, you're starting all over again. You're not dealing with a consistent base of people to administer these programs. You're having to reteach somebody every 4 years what you're trying to do and why it should be done.
So it's not only governments out there, it's governments at the starting
That's
point.
right.
Purana, what's your view?
Sure. So I gave you the benchmark example of Singapore, and some of the developing countries are just miles from there. I'd just like to talk about China for a little while, where I spend quite a bit of my time. The interesting thing there is they really have no primary healthcare system, and everybody goes to the hospital for everything, whether you have a cold or anything, and you can imagine that they have a limit in terms of the number of hospitals they have. What makes that worse is that the hospitals are focused on being a profit center. They're a business. So it's funny, when I talk to hospitals and CEOs in other countries, their focus is improving quality, reducing costs. They want to know how to make more money, right? Because this is a business. And up till now, 40% of the profit of a hospital in China comes from drugs. So if you go and consult today in a hospital, a public hospital, a doctor for a simple consultation would be charged maybe 1 or 2 Singapore dollars. So you can do your conversion. But you can charge, and if you have a simple cold, they would basically prescribe you so many drugs that you look like you've got a bag of candy, and that would be $10. So that's basically how they make their drugs. So from the time that it leaves the pharma, which is maybe the drug costs $1, to the time it hits the consumer, it's up to $23 if you just multiplied. I mean, of course, you have to look at the cost in China. But that's a massive problem. And this has basically now made the whole government go through a massive China healthcare reform. They've made announcements. They're going to put in $100 billion to transform. But basically, it's all about access. You know, people cannot afford in the rural areas to be actually going to these hospitals and getting these bags of drugs that they don't even need, 90% of them, for one, and basically which are being run as profit centers. So some of the things that are happening is that they're introducing the whole GP system. So they're actually going to put 10,000 GPs into some of the cities to start getting people to go to clinics, which is a very new concept in China. Another thing that we're starting to see is the whole use of phones. So kind of the Coke example you talked about, everyone in villages in China have a phone. So if you can't get access to them through any other way, perhaps there's a way you can use their phone to start looking at consultations as well. It's not necessarily easy because, again, similar to the point we've talked about earlier, the people that are the most IT savvy are normally the healthy ones, and the ones that need the help are not necessarily the ones that are going to be, you know, communicating through the use of IT. But again, things like remote monitoring, telehealth, using smartphones. I mean, it's interesting, the number of conversations I've had with telcos about healthcare is phenomenal because for them, that's reach into Africa. Again, same in Africa. You go to villages, you'll get a Coke and a phone. Someone will have a phone, even in India, in the remote areas. It may not be a smartphone, maybe a simple $10, $1 phone, but at least that's a way to communicate. And even from a supply chain perspective, in Africa, we've done some small little research projects where we're actually trying to look at update of stocks of vaccines, et cetera, just reminding on SMS, just sending a simple text and getting confirmation. So that's another area we're seeing. And kind of back to Kevin's point about pandemics, this is something that, you know, I was in Singapore in 2003 when SARS hit. And, you know, as you know, it was in Hong Kong, China, and then, you know, it went to Canada. And interestingly enough, you know, the people that get impacted by pandemics the most are people within hospitals because it's basically there. And of course, the public gets affected as well. So one of the things that, you know, Canada did is that they realized that while from a numbers perspective, I think the number of deaths from SARS alone was something like 40 people, which doesn't sound like a lot. But from a trade and economic perspective, it had an impact of $1.5 billion. People didn't want to go to Canada. They were scared. And the impact in China, Singapore was the same. If you went anywhere in Singapore during SARS, it was a ghost town. Nobody was out. Nobody knew what to do. Surgical masks. Everyone was wearing surgical masks. They had no more surgical mask stock in hospitals. All of a sudden, the surgeons were like, where are all my masks? Well, they're in the public are wearing them. So one of the things that we actually did, we worked with the government in Canada, was to create a pandemic system that actually was looking across the multiple stakeholders involved in a pandemic. And I think, you know, and there's multiple systems. There's inventory management for the stocks, there's vaccinations, there's workload, there's case management, and all of these things. So we developed a system called Panorama with the Canadian government, and we're deploying it now in the Middle East, and we're trying to see how we can provide this as a service to developing countries. But the idea would simply be, think of it as like an ERP system for pandemics, where if, for example, someone in this room had meningitis, everyone in here would have to be quarantined. But immediately through the system, you would know who's been immunized. And then you would immediately have a link into a system to see, do we have enough stock for that vaccination to apply? Do we have enough people to apply it? Now, our idea is for a place like Africa, why not provide some of this on a phone, you know, to the people in the region? So these are some of the thinkings that we have as well.
you sort of, sometimes there are these negative supply chains, the pandemic supply chain that operates and carries what we don't want to carry around with it. Now, I'm going to rename this panel Plus because I've decided that I'm going to extend the panel. So become uncomfortable. We've had enough of this asking questions from the floor. We're going to turn it back a little. Unfortunately, some of you know that you're about to be asked, but what I discovered when I stood back and looked at who was here and thought about what they'd said to me in the last 2 years, or thought about what I'd read about what they were doing, some of them way back, then I thought, I think I'd like to gather together all of the key information that I've got in the room and harvest it and add it to the equation. So, first of all, sitting over here is Professor Martin Christopher. And those of you who've been around the supply chain for a while will know that, along with John, Martin's been one of the real pioneers in this field. And without knowing it, you, if you've learnt supply chain, will have learnt, I would say, from some of the work that Martin did, probably 20 years ago, but you probably learnt it, 5 years ago. But along the way, he wrote about many things and he influenced people that wrote about things. But one of the papers he wrote that captured my interest a few years ago was taking that piece of the supply chain that is the hospital, taking the hospital and looking at it as a supply chain. And that was probably one of the first times it was looked at in that way. Now, Martin quickly moved on from that and he's looked at lots of other things. But what happened and what happens to good academic material is that other people then pick it up and move on. And I was reading a paper the other night and it was citing Martin. Then I picked up another one and it was citing Martin. And I thought to myself, we've got the source here. So I know it was a long time ago, Martin. I know you tell me you've forgotten most of it, but I did give him enough time to see if he could find it, remember. So Martin, tell me what the hospital looked like from a supply chain point of view when you saw it and when you took that snapshot.
Thank you, Deborah, and thank you for those generous comments too. I can't take all the credit for that work. It was actually done jointly with a colleague from Cardiff University, and Cardiff has had a long sort of history of focusing on lean enterprise and lean operations, and that's where part of the thinking came. Also, my colleague has spent a lot of time in hospitals himself as a patient, and I think this, as much as anything, was what was driving his interest in this. But basically, as anybody who's familiar with the UK National Health Service will know, is that it's a very expensive system. Depending on your point of view, it's either world-class or it's a long way from that. But one of the concerns for quite a few years has been that there have been significantly long waiting lists for operations, often high levels of unreliability in terms of cancelled operations, patients having to wait, being given a date and then being told it's not going to happen on that day. And yet at the same time, paradoxically, extremely low levels of capacity utilisation in the operating theatres. At the time we did this work, it was about 25%. In other words, the operating theatre only used 25% of the time, but big queues. And I think what we identified basically was that the problem was that there was no separation between what we might call the predictable and the unpredictable. Predictable operations are what we might call elective operations, things you elect to have done, typically less urgent. The unpredictable, clearly by definition, are the emergencies. And there's a very clear parallel here between the things you've been talking about, things that John's talked about, when we separate base and surge in a supply chain. And the real problem was that this lack of separation meant that it was very difficult to actually plan the use of that capacity. Also, too, a further confounding element is that historically consultants have been allocated blocks of time, and they determine how that time in the operating theatre, and they determine how that time is used. Relatively little central management of capacity, all pretty sort of obvious opportunities for improvement if you were to look at this, you know, as a manufacturing manager might do. And so basically what we really came up with was the notion that there are two supply chains. One is the lean supply chain, which is for your predictable activity, and the other clearly is the agile supply chain, which is required for those things which we can't predict. But that they shouldn't be mixed, that we should separate them. And this, I think, was a fairly obvious conclusion. We put that idea forward. Things move slowly, as you might expect. There's a lot more interest now in the health service in adopting this sort of thinking. There's still a lot of work to be done here, but and I'm not suggesting that everything that happens in a hospital can be run like Toyota. But I think there are a lot of opportunities for taking ideas out of the world of manufacturing particularly and applying them in that particular context.
Yeah. Can I make a comment?
Yes, Fran.
Yeah, so I think that's a great point, because within the hospital, you know, we're definitely learning from other industries in terms of how they're actually managing some of the optimization of workflows. So a simple example is what we call real-time asset location, which typically where you use an ultrasound tag or something on a piece of equipment, and a lot of time big heavy equipment in hospitals disappear or walk out the door. So, you know, being able to track those types of things to manage those assets. But also, interestingly enough, now we're doing patients. So you can actually put a tag on a patient to look at the flow of that patient to see where are the bottlenecks. Why are they spending 3 hours in the waiting room? Why are they now spending more time here? So, you know, we're actually using a lot of those technologies from other industries to see how they can look at optimizing patient flow, as well as even on the asset side within the hospital, linking that back to asset management solutions as well, but also just kind of being able to use this from even a safety perspective. Like for cancer, when you administered drugs, those are basically toxins and people handling them. So how can you track that down to the level of ampule of chemotherapy treatment all the way down to it where it's administered to the right patient at the right time? Sometimes that process is not so seamless in terms of medication administration. So, you know, again, this is just an example of where there is a lot of area for improvement from an operations perspective.
Thank you, Fran. Any other comments from the panel on that? Martin, I'd be interested to hear what you say. You spend your life in the hospital. What do you think?
The hospitals now are really struggling financially, so everything is being looked at to try and optimise efficiency. Our hospital, for instance, has a unit that tries to predict the patient load. So it works together with the public health system, and it has early warning of epidemics. So we know, and there's historical data that, for instance, in certain number of months, be it July, August, our winter, that there will be an increased prevalence of influenza and children coming in. So beds will be opened up, and then in summer, those beds will actually be closed. So our bed numbers, it's a dedicated children's hospital, but it actually varies between something like 220 and 300 beds during the year. And sometimes we get it wrong when all of a sudden there is an epidemic of food poisoning or something like this that comes through. But really the hospital a strategic unit is getting it right more and more, and this leads to significant savings. In terms of trying to plan the agile versus the lean. One of the difficulties is that often it's the same surgical team that is going to be used for, let's say, a routine orthopedic operation, be it a spinal reconstruction or so, and then all of a sudden you have a major car crash with spinal injuries, and it's that spinal team that's taken out, and that disrupts this kind of clean separation between an emergency theatre and a theatre for electives. And this leads to a lot of disturbance because families have planned to come in for that elective operation, and leads to a lot of heartache. So it actually, in real life, it turns out to be very difficult to implement, even though it makes a huge amount of sense.
We've recently had a hospital in Melbourne that has separated acute and scheduled and basically made two hospitals out of it to be able to manage them differently and to manage those flows differently, which when you think about it is responding to Martin's important early observation.
Could I just add to that, in that for routine operations, it might be an appendicectomy, it might be tonsillectomy or something like this, those are shunted almost to a private hospital setting that has a limit on the complexity of operations that it does. And the main hospital is now being used more and more for the high-end
For the high end, yeah. So that natural separation.
So, Doctor, you've actually unwittingly provided a good metaphor for supply chain, because every day we come in to do our standard operations, and every day there's a car wreck that enters into the process. Yes. But you also touched on something, actually both touched on something, and that's the adoption of technology, standardized supply chain technology into the hospitals, RFID, 2D barcodes to manage and regulate the amount of inventory coming in. We're doing some work recently with a major hospital chain, and they've got a new program that they call 1 Not 5. What does that mean? It means that historically, traditionally, whenever they've gotten a shipment of a particular product, they were sent 5. It didn't matter if they needed 1 or if they needed 10, they got 5. And what they're saying now is, in order to manage this more properly, when we need 1, we want 1. If we need 2, we'll tell you we need 2. That's what we want to get, not 5.
Now, on the basis of panel plus, I've got another +1 planted out there in the audience. Gerard de Villiers, if you could stand, Gerard. Gerard used to head supply chain for World Vision. He comes from Africa, and now he's back in the commercial world like the rest of us. But I thought it'd be interesting to hear his perspective on his time in that operation and what he saw of this problem in Africa. And
thanks, Deborah. I just want to say that, yes, I am African. I'm just from the white tribe. We've been there since 1680, the French Huguenots going out. So I'm, in fact, the 10th generation of Huguenots that went to South Africa. Deborah, thank you. It's now a year that I'm away from World Vision, but I want to tell you a quick story. And then, if you allow me, just one comment on the current situation, maybe in healthcare distribution in South Africa. But my story about World Vision, it was in the early days when I joined them as Chief Logistics Officer, and I visited a small little settlement village in Zambia. It's to the west of Lusaka, close to Kafuwe National Park, in an area called Mumba. And the head of the area was Chieftainess Kabulwe Bulwe. And I was there with a few of World Vision people, and we were building a school in that area. And at the end of our engagement, I asked Chieftainess, what can I give you? I want to give you something, a present. And she said to me, obviously through interpreter, she said to me she would like to have a bicycle. And I said, sure, what do you want to do with a bicycle? She said, no, my messenger is walking through my area, and it takes him too much time to carry my message to the people. I want a bicycle. Now, regardless to say, the next day she had a bicycle. I made sure she, or her chieftain, or her kingdom, or the area, tribal area, could get that bicycle for transport. I share this with you to share with you the challenge we have in supply chain management to the last mile, to the last person. What we did in World Vision is we did not distribute medicines or get involved with healthcare support per se. However, we had AIDS caregivers and caregiver kits that children would pack for us throughout the world in a little customized crate, and that would be sent out to people who would care for patients who suffer from AIDS. Because at the last stage in their life, to help them to die with dignity wherever they are, they need someone to support them, to clean them, to wash them. And that would be the support that World Vision would then give out into the field. So that's a story about World Vision. Obviously, different supply chain that we think of normally in the developing or developed world. In a South African perspective, I must admit that South Africa is maybe not a typical African country. Yes, indeed, we have so many first world characteristics, but also some challenges. I think our supply chain management profession is well developed, and we have 3PL service providers who are excellent, world class. You mentioned PhD earlier, and yes, indeed, they're from South Africa, and they're doing an excellent job. Before I joined World Vision, I was doing a distribution strategy for Aspen Pharmacare. Aspen Pharmacare is the largest generic antiretroviral medicine producer in the world, with grants from PEPFAR, with grants from Bill and Melinda Gates Foundation. And the challenge they had, you were talking about the Coca-Cola through all the remote places, the challenge that Aspen has, how do I get medicine, HIV/AIDS medicine, registered in the different countries, especially African countries? And we go back to Kevin's comment earlier about the governments. And the challenge is that it takes months and years to get a country to say, I'll use nevirapine. And I'll get nevirapine approved in my country to be used. So that's the first challenge, is to get approval to use the medicine in a country. Once I have approval, then you're going to start talking about the supply chain. So the challenge, I don't think, is the formal distribution networks. Our 3PLs do an excellent job. May I conclude by saying the challenge, I think, is in two areas. One is in the governmental distribution centers, where we have so much unfortunate, so much theft and corruption, and medicine lying there that has gone long beyond their supply, sell-by dates or shelf life, because of corruption, because of incompetence. And what's the challenge for us as service providers? How can we get into that distribution center and manage it for government? That's our challenge. And the second challenge is between the door of the hospital and the door of the theater. What is happening inside that hospital? Demand planning. Do they know what they need? Do they know how much of which medicine, how much of surgical masks and whatever is required? That is where we need to go inside. That's what we will do in the private sector. In the fast-moving consumer goods, you as a service provider go to your client and say, how can I help you plan better? How can I help you determine your demand better? And that's, I think, our biggest challenge. Thanks, Deborah.
Thank you, Jerry. I keep coming back to this interesting point that gives me some hope, and that is that, you know, goodwill can only go so far. You know, it seems as though the breakthroughs are coming through commercial solutions. And I think the 3PL, you know, in many ways, this is our conduit. We all use third-party logistics to distribute our goods. We have expected them to lift their game. We've expected them to develop. And what I've seen in the last few years, on two fronts, I think that there is one great business opportunity, but I think two, great hope that some of those commercial learnings are going to be transferred into, you know, this area and make a real difference. Just to reinforce your point, yes, I think that's really encouraging. And the other thing is that on the other front of humanitarian issues, in disaster relief, 3PLs are also doing some fabulous work. DHL, Toll have divisions, but DHL has, you know, an emergency response, you know, airport set up, just waiting to go for the next, you know, we've 5 years, you know, I've been looking at this area, and these things have happened in that time, and that gives us hope. When we read our grim readings from last night, at least perhaps there's, you know, there's some light. Now, Panel Plus, again, I've also got another client sitting in the audience. And Don, who you've heard speak a little while ago, Lamasoft have done some interesting work in the last few years in this space as well. They've been working with the organisation, with WHO and I think, and the organisations that are working here, with decision support tools. Now you think sophisticated solution, you know, how does that make sense in this environment? So we're really out of time, Don, so can I get you to do the elevator version again of what you see happening?
Sure. Check. Yes, I'll do just 2 minutes. Thanks very much, Deb, for giving me a chance to talk about this pretty important issue. One thing I kind of detect, we talk about them and those people over there and us and over here, and on the optimistic side, it's been Lamassau's great privilege since we started our public health practice about 5 years ago to have the opportunity to go in and work in many of these same developing nation public health networks. And one message I want to give to you is they're supply chain people and we're supply chain people too. So they're struggling with many of the same issues. They're struggling with, there are plenty of corrupt American companies and there are plenty of lazy, incompetent European companies. And the situation is they're having to do more, these supply chain people in the developing world, having to do more with much less, with a much greater impact, much greater importance than many of us who are working on commercial issues. So, but one thing, an additional thing that is quite similar is the issue of designing supply chains. And if you take this further and away from the technology, they don't need the sophisticated technology. Many of the problems, it's not a math problem. But what we are trying to do when we apply design thinking is to try to get people to envision that change is possible, improvements can be made, and it's not just all on intuition and gut feel. And I'll give you conclude with one short example here. We've got a team that's been on the ground. I was in Port-au-Prince in Haiti with my team working on, and we continue to work on, the supply chain design for the public health network there. Yeah, we're using sophisticated tools, but it's not that big of a country. There's not that many roads. But it still comes back to getting, when you put up a map and you put locations and you say, in a country this size, do you need 14 different distribution centers? Do you need to have a stocking point here and another stocking point 2-hour drive away? Well, there's reasons why it evolved that way. But when you put it up on a map and you show them and you say, this is the cost of doing it like this, and you can get the same level of service with far fewer points, and in fact, you can then conserve and do risk pooling, you get an even better service level out of the current investment. And it doesn't really matter so much about the algorithms and the math. It matters of getting the people who are running these systems to think about it that this is a system that is designed, not just one that has happened to me. It's no different. These guys are struggling with the same issue of moving from reactivity to proactivity. It's the same issue. Commercial, public health, and developing world. Design thinking is essential to moving ahead.
Thanks, Don. So, I don't have any more plants. So I quickly open the questions. Over here, please.
Yeah, I'd just like to make an observation that's coming through to me around the whole issue of transformation, and that's this. I think the work that's happening and the thinking around supply chain is going to be maybe the major driving force for changing how this world works. And I'm thinking of things like the notion of putting transportation hubs in countries that are going to transform how cities are actually designed. And I'm thinking about the fact that we're dealing with cycle time reductions that now make it almost impossible for governments to solve problems, the types of problems we thought were government problems. We're now kind of pulling those problems into the private sector, into consortia that cut across the supply chain. And I just want to reinforce something that I said on the panel a couple days ago, and that is that this is maybe the major locus of global transformation, what we're all about, what you're all talking about, and it's just very exciting to look at the implications here. But there are going to be massive, massive changes. I mean, I've lived in Africa. I've seen some of these breakdowns, and government, both in the United States and Africa and all over the world, are showing that they can't react fast enough And I think some of the things we're talking about are going to fundamentally transform even what we're delivering in our more private sector supply chains. So it's just very exciting to hear all this.
Thank you. Roddy?
Having led the AMR healthcare practice for a number of years, and in fact, we had a few healthcare summits. And one of the interesting things of the healthcare summits was we had pharmaceutical companies, medical device companies, hospitals, distributors in the same room. And the first year was like a high school dance. Everybody was hiding in the corners, and there were sort of lawyers in disguise sitting all over the room. However, 4 or 5 years later, that's become almost institutionalized in AMR. And I think the key points that came out of those healthcare summits was, and we haven't touched on it, and I think they're quite significant factors. One is there is a lack of trust between the components and sectors or the pieces of the distribution channel in the healthcare system. They don't want to share information with each other, because a pharmaceutical company with a 75% margin is not going to give that margin up to a hospital who's battling to make a 2% margin. So that's a very fundamental constraint. So that lack of trust and that lack of information sharing is a very serious constraint to operating as an end-to-end system. However, at the AMR Top 25 conference about 3 weeks ago, Jim Cafone, who's the Chief Supply Chain Officer of Pfizer, gave the most enlightening presentation I've ever heard from a pharmaceutical company. And basically, I think Pfizer is scrambling because they're losing those patents, and they've got to survive. So what they've designed is taking the whole healthcare supply system in Pfizer to the cloud. Because they're saying, you know, if you have a life-saving drug that you happen to have lost in your luggage, and you arrive in a country and you say, I've got to have this drug because I can die, well, you've got to first go and get a doctor appointment, and they've got to prescribe the drug. You can't just automatically get it. And they're saying they're going to deal with that by taking all of those regulations and all of those capabilities up into the cloud. Now, it's a long shot, and it's going to take years to develop. But the point is, you never heard this vision 2 years ago. They said, we'll just stuff the channels full of inventory because we make so much money, 89% margins, 15% COGS. We just hold 300 days of inventory. That's how we deal with the supply chain. So there's definite movement. And this is a very first world perspective. You know, the third world perspective, I think we'll see the benefits of this, because if you do take it to the cloud and we do build this information management layer that we can share more, learn more, get more visibility, then I think a lot of these problems, just by way of latency, go away. Or get better. I don't think they'll ever go away.
Any other questions? Okay, I might wrap up and release you. Thank you all for sitting in on this. I know that you probably thought, this is not my area, you know, I'm not sure about this. But I'm grateful, and I hope that it has helped you the way looking at this area has helped me. It gives you a perspective. It gives you a perspective on everything else, and, you know, it sort of creates a bit of a hierarchy of need, you know, and attention. But I think, like all things, you know, the area that is behind will often leapfrog, and there's going to be lessons, and I think what Farana talks about has lessons for us, and I think there are lessons, you know, in many areas that we'll be able to absorb into other supply chains. But I think too, also for we as professionals, there is a need for sophisticated points of view, that there is a need for the supply chain mindset. I had questioned that myself, and I have kept asking myself, you know, is it just the supply chain ego that thinks, yes, we can solve this too? But I've convinced myself, I think there is something to contribute in this space. And, but I think in combination, you know, I don't think, you know, what we've got to offer can only support the medical profession. Our job, you know, I go back to the Ralph Lauren example. I thought that was a very good expression. You know, the supply chain's job was to support the brands, because the brand is what this business is. Supply chain's job is to support the professionals that keep people alive. You know, we are not it. We are the support act. but I think we can become a much better support act, and you know, there's great opportunities for us to really make a difference. So thank you very much, and thank you particularly to the panellists, the genetically engineered panellists, very appropriate then to think for health, particularly for our patient and professional representative, Martin, Kevin, for your wise and insight and experience, and for being the other supply chain person, so at least we could talk some of the same language. And for Farhana, thank you, and I do applaud what IBM's doing in this area, and I watch with interest. Thank you.
And of course, let's all thank Debbie for her able chairing. I just better take you through the remaining little bits of the agenda, because John has revised them somewhat. There are only a couple of things left. We're going to go to Russia in a minute, and I'll introduce that just in a moment. It's quite a surprise. Then John has decided to combine the open forum and summary and final word and close, which were two separate things, into one, with himself and Bill Marin. That will follow Russia at 1 o'clock. And then about 20 past, we'll have our barbecue, which is one floor up and down at that end of the hotel where the buses can get in. You know, the hotel kind of tapers. There's an area that's inside and air-conditioned, it's not hot. And one other word I've got to tell everybody is the Katorna team has arranged a late checkout for everybody here at 2 o'clock, but don't go beyond it, or the hotel will be talking about a half day's extra room rent. Thank you. Now it's time to talk about Russia. We've got two members of the Katorna network who've come from Russia, Konstantin Maximov and Ilya Bundyur. Konstantin is from Harvey Logistics and Ilya from Sibur Holdings. I think it is Ilya who's going to talk to us very briefly, for a few minutes, to tell us a little bit about the state of play and supply chain in Russia today. Would you like to come up and... Oh, there we are.
Good afternoon, ladies and gentlemen. Good afternoon. Me and my colleague Konstantin, we are glad to see you at this summit, and we really don't want to advise you how to organize the transportation of Russian dolls all over the world. We want to say some words about the opportunities for logistics developing in Russia, and appreciate Dr. Katorna for this unique chance. And at first, we want to say a few words about our initial legacy. Probably you remember the Iron Curtain of the USSR. At that time, logistics had these mentioned distinct features, and this resulted in next situation. We had destroyed infrastructure, loss of strategic transport centers, and minimal government support and investments. And we had a lack of qualified personnel. You know, today it's only 1,700 post-graduate employees. And we had a lack of 3PL operator market. This is a well-known research of World Bank with the country's position calculated by LPI. Have you recognized our leaders? Yeah, I think that's why we're here. And where is the Russia? Oh, come on. Yeah, here it is. And 20 years of developing logistics have been provided only 95th position, and this time was needed for future sustainable growing, and we expect much more development in the next 10-20 years. So if we compare that transport and service, logistics service between Russia and the world, what can we see? This is a world allocation of the main services: transport expedition service, warehousing and distribution, and logistic management and optimization. And this is Russian allocation of these services, and really we have just 1% of logistic management. And I think it's a real issue, and it's a very big field for work. And what we need to get closer to the world indicators, certainly the investments and the innovation leadership mind. Russian logistics strategy is to integrate our country in the world trade area and to realize the transit potential of our country by these steps. You know, nowadays the branch of logistics and supply chain management is getting huge support by government, and we are developing our customs union with the nearest neighbors, and entering the World Trade Organization, and we are reconstructing our infrastructure and changing our legalization. And nowadays the situation in Russia is as follows. Is it good for our economics? Surely not. But why are we talking about this? Not to make a negative conclusion about our country, but to speak about huge potential of work in our country. We are future generation, we are a new generation, and we believe in the future of Russia. We have our own opinion on the ways of developing logistics in Russia, and we have our own ideas about this, but still we have a lot to learn. That's why we are here. And obviously we are looking forward to getting acquaintance with the new professional people here. We are glad to have a lot of different colleagues in different parts of the world, and we are willing to learn from their experience and share ours with them. You know, next year, together with our partners, we are inviting Dr. Gatorna to deliver his masterclass in Moscow, and we are going to make a conference, and you are also more than welcome. And we're sure that there is a great opportunity for professional people who dedicated their life to logistics to work in Russia. Now quite a lot of international companies are working in Russia, and if you are not in Russia yet, you can easily ask us how you can make it. Thank you very much for your attention. Thank you.
Well, thank you, Ilya, and he's come all the way to from Moscow for this little occasion to participate in this seminar and to address us. So that's wonderful. Thank you for coming. Now, over to John Gatorna and Bill Marin for a little wrap-up session.
Thank you.
Just as we're walking up and Bill's getting his thoughts, Ilya and Konstantin contacted me only a few weeks ago. They picked up a copy of my book and read it, and I was just blown away by the enthusiasm of this young generation of Russians. And I think if we see that sort of thing coming through, it augurs well for that country, which has been having a tough time for quite a long time. Sorry, Bill.
So, John.
Yeah.
How do you feel?
I feel pretty relaxed, actually. I'm looking for a glass of wine and settle down, but I think I'm just delighted at...
Anyone feel like they've run a marathon?
Yeah.
So I just want to first of all say the range that you've created in this agenda was very aggressive, and we covered a lot of territory.
Certainly did. Probably too much, actually.
Yeah, asking anyone to summarize what we've covered in the last few days it would be a task that might take us a couple hours, and I think you only allotted about an hour and a half for this discussion. So, just kidding.
Maybe
just
15,
kidding.
Maybe 15 minutes.
So I had pages of notes. I'm saying pages of notes, and received contributions from many. I looked at that page and said, how could I get it? Those pages and said, how could I get it down to 10 things that we could discuss? And as I sat here for the last half hour, I said, well, maybe how do we get it down to 3 things that we discussed?
Yeah.
And really, I think the thing that might be good for us to reflect on is as everyone starts to contemplate the takeaways that you've had from the last few days, and I really urge you to use your notebook to reflect on the true highlights and takeaways that you had, so you can go back and share those with your team when you return.
Yeah.
So, John, I thought you might just help everyone and help me a little bit here in terms of sharing highlights. I thought we'd just take the key themes, and the first was design thinking, and this was a topic that you raised seems like a couple of years ago as one that we should attempt to do a deep dive on, and now that we've done it, there were some interesting highlights. I'll just lead with a quote and let you react. Does that work for you? And I really believe this was one of the quotes that will stick with me walking away, and that was when Howard Smith proclaimed that there's no such thing as a good supply chain, there's just an appropriate supply chain.
Yeah.
Your thoughts?
Yeah, I think that's spot on because we've lived in a world where there's rights and there's wrongs, but as we get more into understanding that supply chains really are omnipresent in a business and in a society, we come to the view that the only word that sort of can explain what supply chains do is this appropriate word. And I think Howard is a particular friend and for me a role model in supply chain because Howard can explain, if you talk to Howard, he can explain to you in great detail, as good as anyone else at Ralph Lauren, including Ralph Lauren himself, about the brands and the value of the brands and everything else. He's not just a supply chain guy, he's got the business in his DNA. So I think when he uses expressions like that, they're very powerful.
And to follow on to that, I think the other the session that we held on transformation, which no doubt is about how do you apply design thinking.
Yep, that's right.
3 themes emerged from that. One was people, process, and value. I love the statement that was made in that session around a line around your value proposition versus driving out cost.
Yep.
I know that's something that you champion as well.
Yeah, and really, again, it's like it's horses for courses. I've used that expression in Asia before, and no one knows what I'm talking about, but it really was part of the inspiration of recognising that not all customers are the same, and that some customers want low cost and lean, and drive cost out, and that's the value proposition there, but other customers want speed and agility, and that's the value proposition there, and other customers are looking for relationship and continuity, and there's a different value proposition, and some customers, particularly in the area of health and pandemics, are looking for solutions that will solve problems which are massive after emergencies, and there we're looking for fully flexible type value propositions. And the key thing is, don't get the value propositions mixed up. Line them up, and you'll get a lot more. You'll get a lot happier set of stakeholders out of it all.
Yeah. So to wrap up our comments around design thinking, my other favorite quote was that design thinking is optimistic. There should be no pessimistic designers.
No. Well, you listen to the people we had here, Keys Dorst and Don Hicks and Andy Switke, and they're all optimists. They're just, which is great. And I think we even turned Paul Gilding around to be a bit of an optimist towards after a few conversations on the side, didn't we?
We did, in fact, indeed. So let's turn our attention to innovation.
Yeah.
Because that was the other key theme here. My takeaway was that innovation is a mindset, and in supply chain today, we really need to adopt a new mindset as we approach innovation. A couple of things that stood out for me. First of all, Bob McDonald, from 3M, when he made the statement that innovation is creativity made practical and valuable, and then you create culture with your feet, not your mouth.
That's a great comment.
Great comment. Then the third point that came out of the innovation discussions that I thought were interesting was that this whole idea around disruptive innovation, being game changers.
Yeah.
And that was certainly Michael Belfori's comments when he turned to the 3 phases of innovation, saying you go from the idea that, wow, that's a crazy idea, something we may never be able to do, to the second phase where you say, okay, but why would we do that? So you get a conversation going on the opportunity, and then the third phase being, of course we'll do that. Why wouldn't we?
Look, I'm a little bit sort of, I use the word leery at innovation, because innovation is one of these things that you can go into and never be seen again. You can bury yourself in it. We've talked about it. I remember back in the late 70s, early 80s, when I was doing my PhD with Martin at Cranfield, and my PhD was called The Effects of Innovation on Channels of Distribution, because there was a lot of stuff going on in the UK at the time. And I remember actually doing a literature search, and this was 25 years ago, on innovation. It took me a year. There was so much written on innovation, and it's frightening. And it's easy to talk about, but not easy to sort of nail it down. And I think as the years have gone on, I've realised that the term I'll use, we're looking for requisite innovation. So, for instance, depending on the situation, if it's a critical situation or something like that, we want genuine innovation, new products, new ways of doing things, scary goals, take risks, all that. But then on the other extreme of that, other part of that spectrum, there are people out there who just want to innovate to take cost out and make our supply chains completely reliable. They're two ends of the spectrum, and you can't apply, the wrong way around. And then you get other innovations around relationships with our major customers, and they're not interested in new products, and they just want a good, reliable service and deepen the relationship. For them, innovation is about deepening the relationship. It's not about necessarily low cost. And at the other end of that, you've got people who don't want the relationship, they just want speed and agility. So, what I've started to realise is that innovation is a very requisite thing applied across your segmentation, depending on, because if you start giving the wrong innovation to the inappropriate places, you can waste a lot of money and resources.
And that's the segue, you've really touched on it, the third theme of alignment.
Yep.
And I combine alignment with the new business model discussion. I think you'd agree with that idea.
Absolutely, yeah.
Commentary there that you'd want to leave with the group?
I can't say much more, really. I was just blown away by the people we had up here who are all far more advocates than I ever imagined. They're out there doing the work. They're using their companies as laboratories, and that's the only way we can move forward. And in the new business model, that's just a sort of extra super sort of example of alignment, where we go beyond the single organisation to multiple organisations to join in. I think we laughingly talked about the European, I think it was Thomas talked about the European Union. If you actually applied alignment principles to the EU, you never would have done it. I think we've just gone through 30 years of pain, and who knows, within the next 30 years the whole thing may unravel, because it just can't work under alignment principles. There's too many differences.
Yeah, and I guess as we think about the other things that would be the kind of the pluses to our conversations that we've had over the last couple of days, I can't help but reflect on the women in supply chain conversation. I personally felt like that was probably the most lively discussion that we had, and one that really kind of pressed thinking, touched on some incredible challenges. I thought the idea of defining moments, those stories that were shared there were interesting, and no doubt it left you believing that women in supply chain is a theme that needs more discussion, and is one that carries incredible potential in terms of our ability to not only raise the quality of what we do, but to really improve our overall thinking.
Absolutely. I think all of us, I've spoken to a lot of people about that panel, and they just think it was the best panel. Not because it was the women's panel, but because of the content of it, the discussion. And I think if we can get more people into the supply chain of that quality and that ilk, it's going to be fantastic. And I look forward, Bill, to Supply Chain 50 doing something like this.
Absolutely.
I think something drawing on the world population, putting together a panel like that would be fantastic for Supply Chain 50.
Absolutely. Another plus area is the whole leadership topic, and I'll combine leadership with knowledge, because I think there was a very interesting thread of conversation held yesterday on the importance of knowledge management, what it means to create a culture of learning inside your organization, and how that thread can be connected to technology that can really advance your organization more rapidly today, and really push the envelope on your ability to have a more effective supply chain organization from a talent and development perspective.
Yeah, I mean, the technology, the platforms that are available today to do this is so much better than they were 10 years ago. So there's really no excuse. And, you know, I know a lot of the organisations represented here today have got the capability to do it. I just hope that if you're not already doing it, you'll use some of the insights from this gathering to go out and start it. And certainly I intend to do a mini example of that with the feedback from this community we've had here in the last 3 days, to make sure that the insights we're discussing and the insights we've heard over the last 10 panels will actually be captured, because there's no point in capturing them, you know, momentarily and then all dispersing and losing them. It's an aggregative process. We've got to, you know, keep that alive.
Terrific. Yep. The final theme, and I guess comments I would make, is that we talked about complexity and we talked about hard work.
Oh, yeah.
I think if nothing else, the complexity, and that at one point in time, I think yesterday it was said, that's become the new word of the summit.
It has.
Probably the new word that, you know, occurs more frequently in supply chain than ever before. But managing complexity, managing ambiguity is a big deal, and developing people so that they have a comfortable approach and a quality approach to thinking about their decision making. I thought was a valuable thread that, you know, fed.
Oh yeah, look, this word complexity, just about everyone you talk to in the supply chain will use that term. I've got another term for it that I want you to take away and use in parallel, and that word is sophistication. Because years ago, again, it's a bit like the 80-20 rule. During my research, I came across Ashby's law of requisite variety. Now, I don't know whether anyone's heard of Ashby's law of requisite variety, but essentially what Ashby said, and this is going back 30, 40 years, that as complexity in our environment rises, and mind you, our grandparents had complexity too, because, you know, they had to work in a world that they didn't have computers and everything else. But as complexity rises, so also does the need to improve the sophistication of the solution. So along came computers, and, you know, momentarily, sophistication of the solution got ahead of complexity. And then guess what happened over the last few years with terrorism and the volatility in the markets? We're having now complexity get ahead and we're in trouble because we're not too sure how we're going to solve the problems of sustainability. So I look at the world as being literally a battle between complexity and sophistication. And I think in this room we've got people who've got the makings of that sophistication. We've just got to make sure we go out and do more in our education and develop the young generation like we've got here amongst the two young Russians, and you know, the academics in this room have got a big responsibility to you know, contribute to that and get rid of these. I think, I'm not sure whether Tom is there, Tom Maguire, but he gave the example yesterday that, you know, doing an MBA right now is so far out of date compared to where we are in our thinking across industry. You know, all of us have got to contribute to that development inside our companies and inside our universities, so that we can get that sophistication again upwards to compete with the complexity that's always surrounding us.
Terrific. Yeah. Well, there was so much more to share. I mean, we didn't touch on risk. We didn't touch even on the healthcare discussion, which I think is a great example of the complexity of work.
That's just super complex.
The incredible opportunity for supply chain to make a difference in the quality of life in the world today. But John, I think before recognizing you once again, I think the thing I think is most appropriate is for us all to recognize this group and the level of sharing that occurred over the last few days, the hard work you put in making these sessions successful and being here for them. Round of applause for the group. And John, I just want to thank you for having the vision to push forward with such an aggressive agenda and bringing so many of us together. The countless phone calls, research you've done, the quality of the materials, the quality of the programming, the expert facilitation that you pulled together in making this happen. A heartwarm thank you from me and I'm sure everyone else.
Thanks very much, Bill.